From the Department of ENT, you have already started the 3 part of the ENT. That is, Dr. Jisan started the year, and Dr. Ognivo started the part of the larynx, I think. But he didn't take the class due to the scarcity of the student last day, and Dr. Shubonto started the nose. Yesterday I taught the part of the nose, that is the septum, but today I have decided to start another chapter. Today we start the part of the pharynx, and in undergraduate level we are very much concerned with the practical portion, which is necessary in general hospital. Not only not like a very hi-fi hospital like teaching hospital, super specialty hospital, and this type of work is not we accept from the undergraduate student. So, teaching also in that way. We are mostly concerned with the disease and the anatomy physiology of that portion which is connected with the disease. And today the topic is mostly the tonsil and adenoid, the bulk of the lymphoid tissue present in the pharynx and bulk of the lymphoid tissue. I will try to describe the difference between the lymph node and the lymphoid tissue bulk, even present in the small intestine, the Peyer's patches, and in the it is present in the pharynx, upper part of the pharynx, nasopharynx as adenoid and the tonsil. And adenoid and tonsils are the member of the Waldeyer's ring. I come to the Waldeyer's ring. Waldeyer's ring is the superior part. There is a nasopharynx, the adenoid, and the main two on the tonsils, and other is the lingual tonsils and other lymphoid tissue in the pharynx. Now the tonsil, it is the palatine tonsil, dense compact bodies of lymphoid tissue located lateral wall of the oropharynx, bounded by the palatoglossus muscle anteriorly and palatopharyngeus and superior constrictor muscle posteriorly. You just imagine that when you see through the oral cavity, you will see anterior pillar, that is the palatoglossus. That is the anterior boundary of the tonsil, and the palatopharyngeus is the posterior boundary, and laterally the superior constrictor muscle, which is the tonsil. And the arterial supply of the tonsil is mainly the lingual artery, the dorsal branch of the lingual artery, and the facial artery. Basically, you see, this is the system of external carotid artery. All the arteries from the external carotid artery. This is maxillary artery, that is the descending palatine artery, and it is the facial artery, ascending pharyngeal artery. This is external carotid artery, this is the internal carotid artery, this is the tonsillar artery from the facial artery, and it is also another ascending palatine artery from the facial artery, and from the lingual artery, that is the dorsal lingual, to that is the tonsillar artery. This is the arterial supply mainly. The venous drainage, mainly the paratonsillar vein. I will say that is what is the importance of the paratonsillar vein. That is paratonsillar veins are draining from the pharyngeal venous plexus to the internal jugular vein. And the importance of the paratonsillar vein, when I show there is anatomy of the bed of the tonsil, you will see the paratonsillar vein is lying just beneath the tonsil. When we do the tonsillectomy, and the dreaded complication of the tonsillectomy is the bleeding. Dreaded complication of the tonsillectomy is the bleeding, and that bleeding is not the arterial bleeding, that is the venous bleeding. So, don't worry very much for the bleeding after tonsillectomy. And most of the arteries supplying the tonsil, it pierces the superior constrictor and come to the tonsil to supply it. And when the superior constrictor, due to the contraction of the superior constrictor, it is automatically the bleeding is stopped, which is from the those arteries. So don't worry much for the bleeding, but you should tie that bleeding the paratonsillar vein, which is lying the bed of the tonsil. The lymph node is the jugulodigastric lymph node, and the glossopharyngeal nerve and the lesser palatine nerve is the nerve supply. And this is the main thing. This is a very important anatomy, and which is for the head neck person, and also in your exam this is a set question, that is the vertebral fascias distribution and what is the bed of the tonsil. This is a very important anatomy. You see, this is tonsil, this is the capsule of the tonsil, the green one, and this is the paratonsillar vein, just lying on the bed. And beneath that, that is the pharyngobasilar fossa. Then there is a muscle superior constrictor which forming the posterior boundary of the tonsil. You see all the arteries, main artery, the facial artery piercing the superior constrictor and supplying the tonsil. And it is the buccopharyngeal fascia, then there is the medial heart, the pterygoid muscles and the masseter muscles. This is the facial artery is coming, the submandibular salivary gland. That relation is very, very important. And you have one of the question from the ENT, the anatomy question from the ENT. It is a very anatomy question for the ENT. This is very important. The bed of the tonsil, that is very important, and you have to draw the structure. If you can draw it, then the description is very easy, only 3 to 4 lines. You see, this is all these things I have already stated, that is the styloid process, and that is the important thing is the styloid muscle and glossopharyngeal nerve, internal carotid artery, medial pterygoid submandibular salivary gland. And you see that I will try to note that portion, that is the styloid process. Sometime patient complaining of pain which started from the just beneath the angle of the mandible, and it is radiated to the neck, sometimes to the ear also. It is the Styalgia. Styalgia is due to that elongated styloid process, and which give pressure on the glossopharyngeal nerve. That is the Styalgia, and generally as it is a neural pain, we have treated the Styalgia with carbamazepine, and if it is not improved, then we palpate or take the X-ray whether the styloid process is elongated. We palpate through the tonsil whether the styloid process is palpable, and if it is palpable, we go for the tonsillectomy. We separate the superior constrictor, the bed of the tonsil, and we locate the elongated styloid, and portion of the styloid is excised. Next important thing is the internal carotid artery. Each and every time before going to the tonsillectomy, you should palpate the tonsil, because there is a chance of formation of aneurysm. There is a chance of formation of the tumor beneath the tonsil, that is a vascular tumor. The pulsation can be there. So every time before going to dissect the tonsil, you should palpate it. Otherwise, 0.001% case, you will be in danger. You can puncture the vascular anomaly, and there is a huge bleeding, and it's very difficult to combat that situation. A difference between tonsil and lymph nodes. That was a very common question. You see, that is a tonsils, adenoid and Pierce patches I have already told in the intestine, all are the subepithelial, and lymph node is a connective tissue, and mostly there is an lymph node has the afferent and efferent, and this is only the efferent, because the afferent coming from the surface, they are exposed to the atmosphere, and that is coming from the all these things they taken in, that is from the outside or from the surface. There is no question of afferent, but the lymph node taking something from the other organs or other part tissue of the body, so there is the afferent. No cortex of the medulla, it is a very much varied type of histology, and no definitely formation of the medulla, cortex, even the follicles. And there is a growth curve is present. What is the growth curve for the tonsil? Generally up to 3 to 4 years, it is increased in size, and gradually from the 8 to 10 years, it is decreasing in size, and sometime it is decreased in size, and the air spaces or the passage of the air around that enlarged tonsil or enlarged adenoid is increased due to the size of the cranium also comparatively increased. So, the passage for the air is increased. You see, this is the adenoid, it is the part of the respiratory tract portion. So, epithelium is ciliated columnar, tonsil is non-keratinizing, and adenoid there is a linear furrows. Linear furrows, it is partly encapsulated in the tonsil, and tonsil has the crypt, and the crypt increase the surface area. If it is just covered by the epithelium, and if it is folded epithelium, and if you elongate that epithelium, the surface area is increased and the absorption is more when it is coming from atmosphere, from outside, any bacteria, any immune protein, or these things is absorbed more by the due to the crypts or due to the furrows. And the peak growth for the 6 years and 8 years, stop 12 years and 15 years, disappear 20 years, partial, but that's not true for everyone. Sometime after 20 years, we have seen adenoid, the partial regression in 18 years, and also due to some fibrosis or chronic tonsillitis, the adult also had the enlarged tonsil. That is a acute tonsillitis or catarrhal tonsillitis, and is generalized as it is a part of the pharyngitis. And when you see the pharyngitis, it is better to call it is a tonsillopharyngitis. The portion of the pharyngitis is more in case of the adult, but in case of the children, the tonsillitis part is more. But the combined disease is the tonsillopharyngitis. It is called here the superficial or catarrhal. The follicular, how you will recognize that follicular, the crypts filled with the pus visible as a yellow white dot. Membranous, multiple follicles joined to form a yellow white membrane. And there is so many differential diagnosis for the membranous tonsillitis. I will come to that part. The parenchymatous, when the infection present inside the tissue, either in a small abscess form or it may be just infected focus, and the tonsil is rayed and it is hugely enlarged. That is the parenchymatous tonsillitis. You see, that is the catarrhal tonsillitis, the features, the rayed hue, and the pharynx, there is also the congestion is present, the pilar is congested, but you see the tonsil is not so much enlarged here. This is the catarrhal tonsillitis, and in case of the adult, it is sometime the pharyngitis, it is in case of adult, most of the cases this is irritative condition. Irritative condition means we have seen, you can heard the name of LPRD and GRD. That is one laryngopharyngeal reflux disease. It is due to the pepsinogen which is refluxed from the stomach in case of LPRD, and there is a formation of the catarrhal or superficial tonsillitis or tonsillopharyngitis. And GERD, Generally, the gastroesophageal reflux disease, it has also pharyngitis or tonsillopharyngitis due to the reflux of the acid, and it is due to the I think the weakness of the valve of the esophagus, and sometimes it is due to the chronic sinusitis. There is a postnasal drip which can causes the pharyngitis even in the after endotracheal intubation also. You see, this is the follicular tonsillitis. This is the spot. The crypts are filled with the pus. This is the pus. This is the follicular tonsillitis. It is a typical feature. Follicular tonsillitis, usually enlarged tonsil. You see, this is the enlargement. This is the anterior pillar. This is the enlargement. The uvula is also edematous, and this is membranous tonsillitis. You see, it is the crypts, which there is a pus point and it coalesces to form a membrane. For the membranous tonsillitis, there is so many differential diagnosis. The first thing is the diphtheria, which is not so common after the immunization program, but in some area in the North Bengal, some area of northeastern Bihar, and some other area also, diphtheria is seen even today after the immunization program, and I will come to the diphtheria later. This is the parenchymatous tonsillitis. You see, this is the tonsil is hugely enlarged. This is fibrotic, and tonsil is not so enlarged. You see, tonsil is not so enlarged, but there is the pus pointing or fibrotic tonsil. If you pressure that tonsil with your tongue depressor, some pus or some cheesy material will coming out. You see, this is the mostly there is the congested tonsillar pillar, enlarged tonsil. Fibrotic tonsil, there is no enlargement. I already show you the picture just before the slide. This tonsil squeezed by the depressor, pressing the anterior pillar, pus come out, and that is the name. I think there is no need of memorize the name so much, the Arwin more sign. Jugulodigastric lymph node is enlarged, and it is also known as the Wood sign. Now, gradation of the tonsil or enlargement. Sometimes you will see in the diagnosis, it is written the grade 1 tonsil, grade 2 tonsil, the enlarged tonsil, and grade 1, grade 2. What is grade 1 and grade 2? And when there is tonsil is not beyond the pillar, that is almost 0 or plus 1, it is less than 25%. That means it is the space between the two tonsillar area. If the less than 20% is occupied by the enlarged tonsil, then we say this is a grade 1 tonsil. When it is 25 to 50%, like it will be grade 2, 50% and 75, it is grade 3, and it is more than grade 3, more than 75%, it is grade 4. And in grade 3 and grade 4, sometime we call it a kissing tonsil, and it causes the dysphagia or difficulty in the swallowing. And this picture is not good enough. I will show this is the grade 2. This is the tonsil, this is the tonsil, this is the grade 2, 25 to 50%. And you see in grade 4, almost it is touched that each other, touches each other. A grade 1 enlargement, this is a picture, live picture from the area, that is a grade 1 enlargement. This is enlargement grade 2, grade 3 enlargement, and that is grade 4. You see, it is the tonsil, and it is the tonsil, this part, uvula cannot be seen, it is almost touching each other, the kissing tonsil. And now the complication. It may be the acute tonsillitis, the recurrent tonsillitis, intratonsillar abscess, peritonsillar abscess or Quinsy, parapharyngeal, retropharyngeal. If you read the anatomy of the perivertebral fascia, you can realize from a dental caries or from a tonsillar infection how the parapharyngeal abscess is formed. and you will get the history of the pain and fever in the tonsil, then fever persists and there is a swelling in the lateral part of the neck. That is the parapharyngeal abscess. What is the retropharyngeal abscess? I have shown you the that is the prevertebral fascia and retrovertebral the fascia, and between the two fascia behind the vertebra there is a septa, and two sides of the septa there is lymph node, and when the lymph node is infected by that type of infection, the lymph node enlarge and the formation of the abscess, and that is the retropharyngeal abscess. If you depress the tongue by your tongue depressor, you will see the posterior pharyngeal wall is swelled, and if it is swelled universally or bilaterally in equal size, then the abscess is just behind the prevertebral fascia. That means not due to the lymph node, because the lymph node is two sides of a midline septum. If there is a abscess in the lymph node, it will be one side and it will push the one side tonsil. But if there is a tuberculosis of the cervical vertebra and it drain into that posteriorly, it will form a abscess in front of that fascia and it will increase the size equally both sides. And what is the treatment? Treatment, if there is a difficulty in swallowing, if there is a respiratory difficulty, generally not happen respiratory difficulty, but sometime due to the excessive infection, the epiglottitis is formed and laryngeal edema is formed, then there is a chance of respiratory distress and you have to go to do the tracheostomy. And otherwise, commonly in a sitting posture, if you stab that retropharyngeal, the most prominent place with a small knife, the pus will come out in a gush and it will reduce very soon without any anesthesia, almost without any anesthesia. And as the patient is conscious, he or she will vomit it out. There is no question of aspiration. And similarly, in case of the peritonsillar abscess or Quinsy, it is another common condition you will face in your clinic, in the OPD clinic. That is the one side of the tonsil or the tonsillar area or the soft palate is hugely enlarged and patient complaining of adenophagia or difficulty and painful swallowing. And some doctors treated with antibiotic, but the improvement. And what can be done? There is no question of anesthesia. That reassured the patient in a sitting posture, take a knife with guide. With guide means you take only, just cover the knife and expose only 2 millimeter or 3 millimeter portion of the scalpel blade, 15 number scalpel blade, and otherwise other part is covered with a leucoplast, and pull the tongue with a tongue depressor and give the neck. What is the most vulnerable point or the most prominent point? That is a line which draw along the anterior pillar tangentially and superior border of the tonsil and cut at a point. That point is the most favorable point for the incision, and you give a small incision and enlarge that incision by forceps, and again there is a gush of pus will come out and patient will be relieved very soon. But if you are not dare enough to do it, then you can aspirate that area with a wide bore needle. That will also help to some extent. Another is the otitis media. I do not know whether it is already taught to you that due to the otitis media, due to that infection, it is a hematogenous spread or by the eustachian tube. The middle ear is infected and the middle ear fluid is there, that there is a chance of infection, that is the otitis media, and that may be acute, causing pain and rupture. Then the pus is coming out through the tympanic membrane perforation, that is acute otitis media. Suppurative cervical lymphadenitis, sometimes it is happen, but it is not so common. But what is the systemic condition? In case of the children, the commonest organism is group A, Streptococcus beta hemolyticus, Streptococcus beta hemolyticus, and that causes the rheumatic fever, the endocarditis, the glomerulonephritis, all these things, and which is not common nowadays, due to the excessive use of antibiotic. And at the time, at the 20 to 25 years ago, there is so many number of cases of rheumatic carditis, rheumatic fever, and we have to treat the patient with benzathine penicillin, the long-acting penicillin. 3-week interval it was given IM for almost up to 25 years. That is the rheumatic fever treatment, endocarditis and the glomerulonephritis can be happen, and it is all due to the that is the beta hemolyticus. And next is the that is the differential diagnosis, the membranous tonsillitis, facial diphtheria, infectious mononucleosis, and membranous tonsillitis can be happen in case of the agranulocytosis. It may happen in Vincent's angina, and this is a granulocytosis and Vincent's angina. It is caused by the fusiform bacillus or spirochete. Infectious mononucleosis, it is associated with the hepatosplenomegaly and lymphadenitis, generalized lymphadenitis and hepatosplenomegaly. And what is the blood picture? Generally gradual increase of the total leukocyte count, and there is almost the 50% is the lymphocyte. That is the infectious mononucleosis, and it is confirmed by the monospot or the Paul Barnell test. And Vincent's angina is a fusiform bacillus. Infectious mononucleosis treatment is the steroid. If you give ampicillin or amoxicillin, it may be happen there is some colored skin rashes will appear, reddish colored skin rashes will appear, and it is not, the treatment is not the ampicillin or amoxicillin or such antibiotic. The steroid is the treatment. And fusiform bacillus of the spirochete, that is the Vincent's angina. There is also the membranous tonsillitis, and it is generally treated by tetracycline, and a granulocytosis is there. Another part, the neoplasm, the leukemia, lymphoblastic leukemia in case of the children, and also in case of the adult, there is the acute leukemia. In case of the adult, it has happened, but now we are very much concerned with the facial diphtheria. You see, in facial diphtheria, the main thing is that the pain, the fever is not so high, not so excessive, but the patient general condition is very much toxic, and there is lymphadenopathy. And if you see, the membrane is not limited over the tonsil only. It is extended over the pillars. It is extended, if you see the posterior corner of the nose, sometimes it is extended over the larynx, that is the laryngeal diphtheria. And treatment, I think already you have read it, either in the community medicine book or in the general medicine. That is, you admit, and according to the duration of the symptom or the duration of the disease, you will treat with the anti-serum, the diphtheritic serum. Before that, we will do the skin test, and along with that serum, you will treat them with either by the penicillin or by the amoxicillin. And one thing, sometime it is needed for the laryngeal diphtheria, tracheostomy is needed for the diphtheria. And I do not know, you can ask your senior doctors. We have seen there is so many babies lying on the bed in the ID hospital, Kolkata, will tracheostomy. 3 years, 4 years, that is tracheostomy. This is only due to the fascial diphtheria. It is extended to the larynx. That is this is fascial diphtheria, the dreaded condition, but now it is diminished due to the immunization program. What is the treatment? Main treatment is the bed rest, adequate hydration, and either the ampicillin. Still now it is the amoxicillin, ampicillin, this group, and amoxicillin with clavulanic acid. Erythromycin is the drug of choice. Antihistamine decongestant is given to relief from the symptomatic relief of the nasal blockade or the mostly acute tonsillitis. Most of the cases in the clinic you will see it is started with the running nose, fever, then after 3 to 4 days, now it turns due to the secondary bacterial infection. So, there is a associated feature of nasal congestion, and decongestant like xylometazoline, oxymetazoline is needed, and antihistaminic like cetirizine or levocetirizine is needed. And for the pain you can give the NSAID, but nowadays we prefer the paracetamol, even for the children also, and antiseptic gargle, treatment of focus of the infection, where that is the if there is any other part, there is an infected organ or any other associated disease, we should treat it. Difference between membranous and diphtheria, you see the membranous tonsillitis, diphtheria is 2 to 5 years, acute and insidious onset. General symptoms is more in case of the membranous tonsillitis, and in diphtheria is less. If you see, that is the agranulocytosis or infectious mononucleosis, or it is a membranous tonsillitis, that means all the follicles, the discharge from the follicle coalesces with each other and form the membranous tonsillitis. The general symptom, the pain, the fever is more in comparison with diphtheria. Adenoidophagia is more, temperature is high, in diphtheria it is low, but the tachycardia. The complication of the diphtheria is endocarditis. There may be chance of meningitis, diphtheritic meningitis. So the tachycardia is disproportionate with diphtheria. The tonsil not so enlarged, but there is a membrane in the diphtheria. If you try to peel it off, there is bleeding will come out when there is you try to peel it off from the tissue. That is a characteristic feature, but we have seen there is some other membranous tonsillitis. There is also chance of bleeding if you try to peel it off. So, do not take it as a very definite feature, but one thing is that is the diphtheria, there is a very toxic look, and it needs urgent treatment, because sometimes it is extended to the larynx, tracheostomy is needed, and it need antiserum, otherwise it will extend more, and it will do the endocarditis, and that will be the cause of death. And that is the membrane, the diphtheric membrane is those who have the experience, the diphtheritic membrane is a different feature. It is very ugly looking. It is whitish grey, ugly looking and scattered everywhere. That is the diphtheretic membrane. And they have written that there is a culture, but if you take a smear from the diphtheretic membrane and you see under the microscope, and you can see the KL, Klebloephlus bacillus, like a Japanese alphabet like a Chinese alphabet like feature, and that is the Corynebacterium diphtheri, and you see the lymph node. In case of the tonsillitis, it is only the wood sign, the jugulodigastric hard nodes can be there, but in diphtheria there is a bull neck appearance. Multiple enlarged lymph node is there, and which is also present in infectious mononucleasis. But infectious mononucleasis has hepatosplenomegaly, which is not present in diphtheria. Fascial diphtheria, you see there is a benzyl penicillin. Do you read that about that drug, the benzyl penicillin? I think you have completed the pharmacology. Is that so? Do you read it, or it is now obsolete? What is this? What is your answer? It is obsolete like a medieval history of India. Okay, but this is the drug. One thing I want to mention here. Last 10 to 15 years, we are not habituated to using the cotrimoxazole. Trimethoprim and sulfamethoxazole combination, that is the cotrimoxazole. Now, last 1.5 years, again the culture sensitivity report is coming for some atypical bacteria. They are sensitive to cotrimoxazole. The bacteria are changing themselves continuously and try to survive from lakh years after there is the formation of the earth. Think about the azithromycin. You are sneezing, you are coughing, across the counter, you are taking azithromycin. What happens? No result. Why? Because we are vehemently use the azithromycin during the period of corona. But azithromycin is not the treatment of corona. Only is the methylprednisolone, and this is the treatment of corona. Ultimately, it was decided. But what happens? Now the bacteria almost are resistant to azithromycin. But when we are internee or house staff, then azithromycin was an atom bomb like. The pediatrician never used it. Always kept aside. When no other drug responds, then they given the azithromycin only for 3 days and very cautiously. That is a miracle result. And same thing with the chloramphenicol for enteric fever. That will happen within few years. Again, the drug will be the chloramphenicol, the drug for the enteric. And this is the antitoxin dose. I do not want to mention it because you will read it in the community medicine or in the general medicine. Emergency tracheostomy, and that is due to the stridor, that is due to the extension of the diphtheria, that is the laryngeal diphtheria. And recurrent tonsillitis, retention debris, that is the pus. You see, this is the tonsillolith. This is the tonsillolith. The patient will come to you. Hey, Dr. Babu, amar tonsile pray sada moto kichu ekta jome, ব্যথা হয়, খেতে পারি না, তারপরে একদিন we huck it out এবং দেখি there is a bad smell. You will see the crypts of the tonsil is filled with a very whitish material, and it is mostly some salt, either magnesium or like that, and other the discomated epithelium filled up the crypta magma. That is the superior crypt, which is sometimes it is the depth is more in comparison to the other, so the tonsillolith is formed. it's a very benign condition, and you reassure the patient. Only the antiseptic or warm saline gargle after each meal will improve the condition. But if there is a recurrence and it forms the ulcer over the tonsil, then you have to go for the tonsillectomy. The tonsillar cyst, you see, this is the crypt of the tonsil. Suppose you block that, the neck or here, what will form? That will form a cyst here, and very faded color and is enlarged, and mostly that is present in the superior or inferior part. Here is another picture of the cyst. If it doesn't produce any symptom, no need of excise it, but when it produces symptom or your patient is very much nagging, then you have to excise that or the cyst only. If you just give a nick and the material will come out and that will reduce. Drainage of the cyst and the tonsillectomy. Keratosis pharyngis. It is not only over the tonsil but also over the pharynx. Hyperkeratinization, epithelium, no inflammation. Hypertrophy and hyperkeratinization of the epithelium and the yellowish horny growth. Reassure, and if the condition is so severe, you can do the tonsillectomy, but nowadays we try to reassure it, it is not the indication for the tonsillectomy. Unilateral tonsillar enlargement, that is the unilateral, one thing is the true enlargement, another is the false medialization of the tonsil. The false medialization of the tonsil due to the parapharyngeal abscess. Tonsillitis and the parapharyngeal space, there is abscess form and it pushes the tonsils medially. Similarly, internal carotid artery aneurysm, tumors of the deep parotid lobe, cervical lymphadenopathy. But in tonsillar causes, that is the tonsillar unilateral involvement, we are very much concerned with the unilateral enlargement of the tonsil, that is intratonsillar abscess or the tonsillar malignancy. So, bilateral enlargement of tonsil, we are not very scared of this thing. But when we see there is a aged patient, even the young one with a unilateral enlargement of tonsil, we are scared because that can be a lymphoma. Mostly the tonsillar growth is the unilateral enlargement of the tonsil is the lymphoma. It needs the excision biopsy. No question of the punch biopsy or like this thing. There is an excision biopsy. You excise the tonsil wholly. And epidermoid carcinoma or lymphoma. Now the adenoid. Adenoid, this is the symptomatic hypertrophy of nasopharyngeal tonsil. Main thing is that if the adenoid is enlarged, imagine the anatomy, it will block the posterior choana. That is the nasal blockade. And bilaterally there is the opening of the eustachian tube. Due to the enlargement of the adenoids, there is the block of the eustachian tube. What happens? Eustachian tube is blocked. Eustachian tube used for equalize the atmospheric pressure from outside and inside the middle ear. But when it is blocked, there is a sudden the atmospheric pressure change in the middle ear cavity. What happens? They absorb by the vessels, middle ear. The vacuum is created. In place of air, there is the transudation of the fluid. And there is a glue-like fluid causes, there is a serous otitis media or otitis media with effusion, and which is very common in case of the children, as there is the adenoid enlargement common in case of the children. And what is the adenoid facies? the adenoid facies, that is the adenoid facies. I will, I don't know whether the features is there. Yeah, this is the adenoid facies. It is the elongated face. Retrognathia of the mandible. There is not so retrognathia, but there is presence of retrognathia happens in case of the dull expression. Expression is dull. Dark circles under the eyes. Open mouth. Mouth breathing. As there is adenoid block, the posterior choana, there is obstruction in the nasal breathing. So, the mouth breathing happens. Pinched up nose. Pinched up nose. Hitched up upper lip. Upper lip is elevated. The open bite and protrusive maxilla, the posterior cross bite. That means, most of the cases when there is a normal occlusion, the upper teeth come just beyond the lower jaw. But in case of the adenoid facies, there is a gap, there is a malocclusion between the lower jaw teeth and upper jaw teeth. There is a gap, prominent and crowded upper teeth. Prominent and crowded upper teeth. Most of the time there is we have seen the child with the incisor teeth are very much prominent. And what is needed? Another thing is important, that is the high arched heart palate. This is, if the nose is open, the baby is suckling probably and continuously swallowing the saliva and the tongue giving pressure over the hard palate, and there is a molding of the hard palate, the flattening of the hard palate. And when there is a mouth breathing, the tongue is down. It's not molding the hard palate. The hard palate will be like that. High arched palate. And that is the adenoid facies. Some orthodontic procedure is needed for the situation. And what is the rhinolalia clausa? That is the flat toneless voice. Difficulty in feeding, snoring, pulmonary hypertension. Pulmonary hypertension is due to that there is a obstruction in breathing and there is a hypercapnia to the pulmonary hypertension and ultimately leads to the right ventricular failure. Obstructive sleep apnea in case of the children. I think you have to know the term obstructive sleep apnea. During the sleep, there is an apneic spell. There is a snoring, the pitch is going high and sudden the respiration is stopped. That is the apneic spell. Then again the snoring is starting from the very low pitch. Again it is going up. And that is the obstructive sleep apnea. Obstructive sleep apnea in case of the children, it is associated with enlarged adenoid and adenoid tonsillectomy is needed. Mouth breathing feature, this is already I have described. Eustachian tube blocked, the expression due to the OME are described. Other features is the nocturnal enuresis and pectux excavatum, that is the chest feature, structural feature. Nasopharyngoscopy, which is the diagnostic for the enlarged adenoid. We can do the CT scan of the nasopharynx or direct nasopharyngoscopy to the enlarged adenoid. We go to the posterior choana and we see this is the adenoid, that is the inferior turbinate, this is septum. But this is, nasopharyngoscopy is the diagnostic nasopharyngoscopy, is the procedure for diagnosis. And this is an X-ray, though it is a very old method it is the Japanese professional Fukuda's take for diagnosis and the decisive one for doing the adenoidectomy. You see the lateral soft tissue X-ray of lateral view of the neck, and this is the adenoid. This is the pterygoid plate and this is the soft tissue shadow. And there is a constriction of the air passage. Management, the nasopharyngoscopy, the plain soft tissue nasopharyngeal lateral view, treatment mild symptom by antihistaminic decongestant and severe symptom is the adenoidectomy. The 5 minutes late, I will just describe you the procedures of the adenoidectomy. Adenoidectomy done nowadays. Before that we done, if you can see when I will show the instrument, there is the adenoid curette with cage and the patient in position, not in the position of the tonsillectomy. Here the neck is not extended, better to say it is a flexed neck, and it is the oral endotracheal tube. If needed, the soft palate is elevated by a catheter, passes through the nose and taking out to the mouth and tie it up outside, and the palate will elevate and you curate by a fashion the adenoid. This is the old method, but nowadays by the endoscope, we introduce the nasal endoscope anteriorly and we introduce a debrider. Debrider means it is the instrument which cuts the tissue like a biting like a mouse. There is a different curvature of the blade, and by the debrider we cut the adenoid completely from the every corner. This is the recent method, and after that we can do the hemostasis either by pressure or by another advanced instrument which is known as the coblation. Coblation is a process which is like cautery, but here is the, you just smoothly surface it and the hemostasis will be done. Now go to the tonsillectomy. The tonsillectomy is a different procedure. The older the procedures are the dissecting methods. Till now we are doing the dissection method, and we are hold by the tonsillar holding forceps, and the position is different. Extended neck, roses, this is the position, and there is the extended neck, and there is a intranasal intubation if possible. If not, adenoid is hypertrophied. If adenoid is hypertrophied, you can't introduce the endotracheal tube. So oral, by the oral intubation you can do it. Nowadays the intubation is such favorable by the expert's hand. And then you drag medially the tonsil by tonsillar holding forceps, give an incision over the anterior pillar, and you just dissect the capsule of the tonsil, and along the capsule will dissect the whole tonsil from the bed up to the lower pole. And there is a name is the Negus hemostatic forceps. It is a curved hemostatic forceps. You hold the lower pole and tie it and remove the tonsil, and again you compress the bed of the tonsil for 15 minutes. Then you remove the pack. If there is a bleeding, I have already told you the bleeding is from the Paratonsillar Vein, and you hold that, and again hold by the Negus hemostasis and tie it up. But nowadays, after the coblation is coming, the coblation, the instrument, you just place that instrument over the surface of the tonsil and it will cut and cauterize, simultaneously. The two processes going on, even the suction. Nowadays, the young persons doing the tonsillectomy by the coblation. But the dissection method by coblation, before dissection there is a snare. Snare means there is a where you cut the partially the tonsil by the snare. But there is a dangerous method, it is a dangerous method. If you cut the tonsil partially, there is a chance of bleeding very much post-operatively. And postoperative complication, there is so many other complications, septicemia, anything, but the main complication apart from the question will ask, that is the bleeding from adenoidectomy and from the tonsillectomy. The primary bleeding, the second reactionary bleeding and the secondary bleeding. Primary bleeding is during the operation. You will hold the area properly, otherwise the bleeding will continue. And the reactionary bleeding, you cannot put the ligature firmly, you rise the vessel conformly. So after 48 hours the bleeding will start. And what is the secondary bleeding? Secondary bleeding generally from 7th day onwards, and it is due to the infection of the operative site. And that is the main area of the question, is the complication.